Hi, my name is Cyrus Khan. I'm one of the hematologists at West Penn Hospital, part of Allegheny Health Network with expertise in lymphomas, CLL, as well as CAR T-cell therapy and transplants. Biomarker testing in CLL is very important. It informs prognosis as well as helps us choose the best treatment options for those patients. In more than 60% of the patients, there will be some high-risk feature at diagnosis. Certain high-risk features are going to negatively impact the outcomes for those patients. If you look at this slide, most of the patients with CLL have a high-risk cytogenetic feature and will likely require a novel treatment. If you look at 17p deleted patients, the median overall survival in years is only 2.6. Compare that to TP53 mutation, 4.8 years. You have 6 years with 11q. You have unmuted IGHV where it's only 6.4 years. Without any high-risk features, it's 10.5 years at this point. Patients with mutated IGHV had a median overall survival of more than 20 years. The NCCN guidelines recommend prognostic testing to provide insights into therapy determination. And prognostic testing is important since more than 60% of the patients have high-risk features at diagnosis. If you look at recommendations for prognostic testing, we should send off FISH to detect trisomy 12, deletion 11q, deletion 13q, as well as deletion 17p. Molecular analysis can be done to detect IGHV mutational status. We check for karyotype to detect complex karyotype, as well as sequencing to detect TP53 mutations. It's getting better now, but I've personally seen some patients coming in and they've been diagnosed many years ago without ever having any of the prognostic biomarker testing done. Now, if you look at this slide, this was an observational registry of a little over 1,400 patients with CLL. Only 28% of those patients had FISH testing, 11% TP53 mutational testing, and IGHV was tested only in about 12% of the patients. And so you can see testing is underutilized, and even when prognostic marker testing is used, there seems to exist a knowledge gap in terms of testing and therapy selection. You can see from this slide that when performed, prognostic biomarker testing is not really utilized effectively to inform treatment decisions. If you look at the top of the slide, 61% of patients were untested for any adverse prognostic markers, and 35% of those patients received chemoimmunotherapy or chemotherapy. At the bottom of the slide, 28% of patients with 17p deletion received chemoimmunotherapy or chemotherapy, despite the overwhelming evidence of poor outcomes relative to patients without this biomarker. Again, talking about TP53 mutation, this testing is critical in patients with CLL. Of the 43 patients with TP53 mutation, 21% received chemoimmunotherapy or chemotherapy, which has been shown to result in poor clinical outcomes for this patient population. Now, if we look at IGHV testing in patients with CLL, in the top portion of the slide, we can see that patients who did not get IGHV testing done, 36% of those patients received chemoimmunotherapy or chemotherapy. But patients who were tested for unmutated IGHV, amongst those patients, 39% of the patients still received chemoimmunotherapy or chemotherapy, despite us knowing that these patients will have poor outcomes relative to patients without this biomarker. One is a knowledge gap. CLL is rare. Our physicians, especially in the community, are busy seeing all sorts of different patients, and sometimes they're seeing 25, 30 patients a day. So sometimes it's difficult to keep updated on what the requirements are for those patients. So that's one obstacle. The second might be availability of the testing, whether their lab can do it or whether it's a send out. These are some of the things that we've been wrestling with and trying to improve out in the community. The current NCCN guidelines do have specific recommendations for patients with CLL. And if we look at the guidelines for patients with CLL without a deletion 17p or TP53 mutation, a BTK inhibitor with or without obinutuzumab is a preferred regimen for patients who are fit, as well as those with comorbidities and frailty. For patients with CLL with deletion 17p or TP53 mutation, a BTK inhibitor with or without obinutuzumab is also a preferred regimen. Second and subsequent lines of treatment of CLL generally follow the same indications as first-line treatment. Asymptomatic increase of lymphocyte counts alone do not necessarily indicate that treatment should be initiated or changed. But if the patient needs treatment, then there are multiple options for treatment of relapsed refractory CLL. Biomarker testing in CLL opens our eyes to what the patient's prognostic status is going to be and how they're going to relapse or the follow-up that's needed for those patients depending on what biomarker they have. For example, patients with 17p deletion, they progress very quickly, and so we need to watch them much closer than patients without that biomarker. In my practice, every patient that needs treatment is checked for biomarker testing. And it's important because we can then decide what kind of regimens the patients might benefit most from. Nowadays, we don't use, at least my practice, much in the way of chemotherapy, but even within the novel and targeted agents, we can choose some of them that we think might work better for those patients. It also helps me have a discussion with the patients regarding their prognosis, as well as formulating a follow-up plan. How often I should be getting their labs or imaging done, how often I should be seeing them. For patients who have certain high-risk features such as 17p deletion, TP53 mutation, 11q- or IGHV unmutated status, I generally go with an agent such as a BTKI, which really should be used in that patient population because we know its superiority against chemoimmunotherapy. Thanks for watching.